Okay, so we're going to talk about Chapter 7, and we're also integrating Faber into this lecture. So this lecture has a lot of information, and it's really important that you study this information as it is directly related to what you are doing in the clinical setting. So read the chapters, also look at my PowerPoint in order to do well on your quiz. So you have a lot of objectives here. Make sure you can answer the objectives. And we're going to jump right into X-ray production requirements, which you should already know. We need to have a vacuum tube. We need a source of electrons, which is our cathode, and a method to accelerate the electrons, which we use voltage to do that, and a method to suddenly decelerate or stop the electrons, which is our target. So they were discovered in 1895. X-rays, beam energy is produced using high voltage electricity. X-rays pass through matter and strike an image receptor. The image receptor converts the energy of the X-rays into an actual image that we can see. So, image formation, we have what's called differential absorption. So differential absorption is where the atomic tissues absorb and transmit differently based on their composition. So the composition is their atomic number or their tissue density. So of course bone absorbs more X-rays than muscle, fat, air within the body. So attenuation, the primary X-ray beam loses some of its energy, so the number of the photons as it interacts with the atomic tissue. So with attenuation, we have absorption and we have scattering. So the classes of radiation, we have the primary radiation, secondary radiation, absorbed radiation, and remnant radiation. Primary is where it's leaving the tube, so where the X-ray photons are coming out of the tube from the target to the patient. Scatter radiation is a type of non-diagnostic radiation, so it comes within the body and it interacts in the body and comes out in a different direction, so it has no useful diagnostic quality to it. There is absorbed radiation where the photon inside the body is absorbed, so it never leaves the patient. And there's remnant radiation, and that's the radiation that strikes our image receptor and gives us our image. So we need to have a combination of the absorbed and the remnant in order to get an image. So we need to see the white and the dark within the image. So as the primary X-ray beam interacts with the atomic part, photons are absorbed, they're scattered, or they're transmitted. So there's the three different things. So you can see your primary photon coming through, and you can see here these photons are absorbed. These guys coming off to the side are scattered, so any photon that changes direction is a scattered photon. The ones that go through the patient and hit the image receptor are considered transmitted. So those are what contribute to our useful beam. So the transmitted and the absorbed give us our actual X-ray. During absorption, the energy of the primary beam is deposited within the atoms comprising the tissue. So we have what's called photoelectric effect, where there's complete absorption of the incoming photon. The X-ray ionizes the atom, so low energy secondary photon is created, and we're going to talk a little bit more about this. And the probability of photoelectric effect depends on the energy of the incoming X-ray photon and the tissue's atomic number. So really important to know the difference between photoelectric effect and Compton. Compton effect is scattering, and it occurs when an incoming photon loses some but not all of its energy and changes direction. It can occur within all diagnostic energies and is dependent only on the energy of the incoming photon, not the atomic number or the tissues. So the photoelectric effect is dependent on the density and the atomic number of the tissue, where Compton is based on the energy of the photon, the incoming photon. So higher KVP reduces the number of interactions overall, but the number of Compton interactions increases in comparison to the number of photoelectric. So as the KVP increases, photoelectric effect drops, where the actual Compton effect goes up. So here's a diagram giving you a visual on how it's working and a step-by-step. So you can see that in photoelectric, it comes in and knocks out an inner K or L shell and gives you a photoelectron. With this vacancy on an inner shell, it makes it very unstable. So it's got to have an outer shell drop down into it. So you can see here, so this would be K shell, this is L shell, it's dropping in. And when it does that, the difference between the two binding energies, it gives off a secondary. Where here with your Compton effect, it comes in and it hits an outer shell, knocks it out, and then you have a lower energy photon. So you have a Compton electron and you have a secondary there, or that's a secondary. So here, I'll show you guys. So in your comparison between the two, your photoelectric incoming photon has sufficient energy to eject an inner shell electron and may be completely absorbed. An electron from the upper shell fills the electron hole. The secondary photon is created because the difference in the binding energies. The probability of this effect depends on the energy of the incoming photon and the composition of the atomic tissue. Fewer photon interactions occur at higher kVp, but those interactions, a small percent, are photoelectric. So we never really get rid of photoelectric, and we'll discuss that later on, exactly why and how, and that goes into another level of class. So Compton effect. An incoming photon loses energy when it ejects an outer shell electron and changes direction. The scattered photon may be absorbed within the patient's tissues because it has a lower energy to it, so it may be absorbed. So Compton can go to a photoelectric, okay, depending on the energy level. So may be absorbed within the patient's tissue, leaving the anatomical part, so it could exit the body and interact with the image receptor or expose anyone nearby. So your dose as a worker in radiation is the dose that you receive is from Compton. So Compton effect or Compton scatter, that is occupational dose. So we are being exposed from the patient's interactions. Kind of crazy, huh? So scatter photons to strike the image receptor provide no useful information. So we want to clean up Compton effect or Compton scatter as much as we can. The probability of this effect depends on the energy of the incoming photon, but not on the composition of the body tissue or anatomical tissue. So fewer photon interactions occur at higher kVp, but greater percentage of those interactions are Compton. Now, the reason why there's fewer interactions with the higher kVp is that the energy of the beam is so high that there's no interactions at all. It just goes straight through the body. So you're going to have just a black image. So there's no interaction. You have to have some photoelectric and in order to see, and some transmitted. These are all transmitted with no photoelectric, or very few, where you can't see the difference in the densities. So although it says fewer photon interactions at higher kVp, that's true. But the interactions that are going to happen are going to be those of Compton. Okay, so you're going to have just a black film with a layer of gray fog on top of it from your scatter. So with working with digital, it makes it really tricky because we want to use really high kVps, but yet we have to find the balance so that we can have some photoelectric in there so that we can see the difference in the densities within the body. So delicate balance. All right, so the attenuation of radiation. So attenuation is the loss of radiation energy as a result of passing through an absorbing material such as the human body. So the degree of attenuation can be high or low, and the high attenuation is with radiopaque matter such as bone, metal, whatever, something really dense, and low attenuation is with radiolucent material such as like the lungs, so filled with air. All right, so factors affecting your beam attenuation. So you have the tissue thickness, the type of tissue, the tissue density, and the X-ray beam quantity. So tissue thickness. X-rays are attenuated exponentially and are generally reduced by about 50% for each 4 to 5 centimeters, which is 1.6 to 2 inches of tissue thickness. So if you're doing a very large person, and it's reduced by 50% for each, like 2 inches, that just is crazy, isn't it? So Also, when we talk about the type of tissue, so tissues with a higher atomic number will increase beam attenuation. Tissue density, so increase in the compactness of the atomic particles will increase beam attenuation. So if you have a 500-pound patient and no muscle whatsoever, it's all just fat, compared to a bodybuilder who is huge, big broad shoulders, huge muscles, that bodybuilder is going to absorb more of your photons than the fat person. So very, very interesting. And you have to keep that in mind. So X-ray beam quality. So high kVp increases the energy of the X-ray beam and will decrease beam attenuation. So if we look here, it's funny because these are the same size, but this is a thinner person compared to a fatter person or a thicker person that's going to absorb more of your photons. So as you can see, I have transmitted X-rays, so a remnant beam here. So this is your primary beam, this is your remnant beam or your transmitted X-rays. And you have here coming in, you have your photons coming in and they're being absorbed by the thicker patient, and you only have a few photons that have passed through. Also, the type of tissue. So you can see here, it's all the same energy. So the wavelength, so the swirly, that is your wavelength. And this is telling me that they're all about a moderate. And you can see the air is got a lot of photons passing through, whereas fat's absorbing some and bone is absorbing most. Okay, so that gives you an idea. So when you're looking at your image, so right down here is your image receptor. So this is going to be white because there's only one photon that got through compared to the air where you got a bunch of photons that came through, so it's going to be darker. All right, so X-ray beam quality. Excuse me. The X-ray or the energy of the X-ray beam affects its interaction within the atomic tissue. So lower kVp results in more absorption in the tissue. Higher kVp results in more transmission. So if we look, you can see the wavelength here. This is a low energy. And the body, since it's lower energy, is going to absorb a lot of your photons. Where if it's higher energy, they are going to pass through and you're going to have more in your remnant beam. So it's going to, if you go too high, you're going to have completely black. There's going to be no or very few photoelectric happening here. So this is mainly photoelectric is being absorbed by the body. So you got to pay attention and you got to get your techniques just right. All right, so factors affecting attenuation. So if we look here, if we have tissue thickness, tissue atomic number, tissue density, and your beam, X-ray beam quality, and you have your beam attenuation, absorption, and transmission. So if we look at your tissue thickness and increasing thickness, it's going to have more attenuation of your beam. There's going to be more absorption within the patient and less transmission. So if you have a decrease in thickness, there's going to be less attenuation of your beam. There's going to be less absorption and more transmission. So you can go through this whole chart and you can take a look at that. Really important you understand how this works. So exit radiation. Remnant or exit radiation is composed of transmitted and scattered radiation. So the varying amounts of transmitted and absorbed radiation create an image that structurally represents the anatomical area. So your transmitted and your absorbed give you your image on your image receptor, whereas your scatter reaching the image receptor gives you an unwanted exposure. So it's representing the kidney over here instead of straight down. So it's going to come out and expose your image receptor over here, representing the kidney when it's supposed to be right here. So we call this unwanted exposure fog. So you'll hear us call it scatter or fog. All right, so your technical factors, let's dive into this. So you have your MA and your time. So MA times time is your MAS. MAS controls the amount of radiation produced in the tube, whereas your KVP controls the penetrability of the X-ray beam, so your beam quality. So when we talk about KVP, we talk about quality. And we talk about MAS, we're talking about density or the amount. And then we have the source to image distance, so your SID. So it's the distance from the X-ray tube target to the receptor, whatever the receptor is going to be. So it affects the relative intensity of the X-ray beam reaching the receptor. Typically is set within Merrill's. We have 40 or 72. Those are the set. We use 48 also, but 40 and 72 are pretty much what you're going to use for your national exam. So these factors are often referred to as prime factors of exposure technique. So these are your prime factors. You have three. You have MAS, KVP, and your SID. So your image density is the overall darkness or blackness of the image. It's directly related to X-ray exposure hitting the receptor. It is affected by your MA, your time, and your SID. So those are, so you can say MAS, or you can break it down to MA, time, and SID. Those what control your image density. All right. MA is the primary factor for density. So MA represents the quantity of the X-ray production. It's a direct relationship, so it's calculated by multiplying MA and time to get your MAS. So when we talk about density, we're talking about MAS. When we look at the different ways to calculate it, this is called the MAS reciprocity law, so we just call it reciprocity law. When I take 200 and multiply it by 0.02, I get 4 MAS. Well, I can change this around and make this 100 by 0.04, and it'll come out at 4 MAS. So that's called the reciprocity. So you can change your MA and your time around where it's going to reach the same value. And that is, so here it says, regardless of the MA and time combinations, the same mass value will yield the same exposure. So that's the MAS reciprocity law. So be able to calculate MAS. It's really important that you can do this. Whether it's a fraction or a decimal, you have to be able to calculate that. All right. KVP controls the beam penetration. So this is your quality. It's a direct relationship. And the beam is polyenergetic or heterogeneous, which means it has a lot of different energy levels. So although you dial up 80 kVp, you are not getting 80 kVp. You're getting a range from 0 to 80. Okay, so it's a heterogeneous beam. Now, when you dial up 80 kVp, you are not getting any photons any higher than 80 kVp. So that is your max amount, okay? So we have what's called the 15% rule. So with the 15% rule with KVP, if you increase your KVP by 15%, you double your exposure. If you decrease it by 15%, you half your exposure. Oh, well, that seems pretty sensitive. Whereas with mass, what we want to do, if we're going to take and increase or decrease our exposure, we're going to go by 50%. So if we double our mass, so if we go from 20 to 40, then it's a double. If we half it from 20, we go down to 10, okay? So 15% rule for KVP, that's usually what we're changing. So 50% halves or doubles your exposure. Now there's another rule, it's 15% rule with mass compensation. So if we want to maintain our image exposure, we like our image exposure, but we want it a little more contrasty, or we notice that the image is starved because our KVP is too high. So we can increase our KVP by 15% and half the mass to maintain the same exposure. So if you decrease by 15%, you need to double your mass to maintain the same exposure. So there's the 15% rule, and that is just if we want to half or double our exposure. And if we want to maintain the same exposure, we need to go up or down 15% by our KVP and half or double our mass. Okay, so those are the two rules that we're introducing for KVP. So there's distance, so SID. X-ray production is similar to a point light source. So if you hold a flashlight 1 inch from a surface and bring it out to 6 inches, the light is going to diverge. It's the same idea. So it behaves according to the laws of light and intensity as a function of distance. So what we have here is the inverse square law. So the intensity of 1 over the intensity of 2 inversely to the distance of 2 squared over the density of 1 squared. So as we change our distance, we will figure out how we need to change our, or it'll tell you the difference between the intensity of the light with the change in distance. So, or the density of photons. So light and photons behave the same. So with the divergent beam, you can, if you go from 40 inches to 72 inches, you are able to calculate the intensity so that you can pick the proper technique. All right, so let's jump into image quality. So there's photographic qualities and geometric qualities. So a proper balance between photographic and geometric qualities is required for optimum image quality. Holy smokes, right? So a quality radiographic image accurately represents the atomic area of interest, and its information is well visualized for diagnosis. So visibility of anatomical structures, so we are looking at the brightness and the contrast, where the accuracy of the structure lines or the sharpness is your spatial resolution and your distortion. So we look here, we have the radiographic quality, we have visibility, and it depends on brightness and contrast, where our sharpness is spatial resolution and distortion. So if we look at image brightness, a digital image is evaluated by the amount of brightness or luminance. So the luminance is the light emission of the display monitor. So a film image is evaluated by the density or overall blackness. So if we're talking about film, we're talking about density. If we're talking about an image on a monitor, we're talking about the luminance. So that's the difference between the two. So you need to make sure that you have the proper brightness, but you don't want it too bright. So you've got to make sure the brightness is correct. So you have here, this is excessively bright, whereas this is too dark. So it doesn't have enough brightness. Contrast. So the radiograph must exhibit differences in brightness levels or densities, which we call image contrast, in order to differentiate among the atomic tissues. So the range of brightness levels is a result of the tissue's differential absorption and of the X-ray photons. So having an image with sufficient brightness but no differences within the tissues. So this would be something like using a really high kVp where it's just passing through everything and there's no absorption whatsoever. So this here, an image with varying levels of brightness. So you can see here that we have multiple objects within the image. So we have some absorption so we can see the differences in the tissues. Subject contrast. So it's a result of absorption characteristics of the atomic tissue radiographed and the quality of the X-ray beam. So the ability to distinguish among types of tissue is determined by the differences in brightness levels in the image or contrast. So contrast resolution describes the ability of an imaging receptor to distinguish between objects having similar in-subject contrast. So we need to be able to see the difference in the scales. So we're going to talk about grayscale, the number of different shades of gray that can be stored and displayed in a digital image. Then there's the scale of contrast, is the range of densities visible on a film. So subject contrast, higher contrast resulting from great differences in radiation absorption between tissues and varying composition. So as you can see here, we have air where it's going to be the most dense and bone is going to be the most white. And when we look here, lower contrast resulting from fewer differences in radiation absorption of tissues. So we have extremes. And then here, they're all pretty similar, but you're going to see slight shades of gray. So this is high contrast because there's a big difference between one to the other. Whereas this is low contrast, they're all pretty much the same. There's not a big difference in contrast. So the thorax is an atomic area of high subject contrast because the varying, you have the heart, which is dense, and you have the lungs, which are black. So the heart's going to absorb a lot in the mediastinum, whereas the lungs, it's going to pass right through. Here's your scale of contrast. This is high contrast because it goes from black to white really fast. And this is low contrast. You have lots of shades of gray. So this is high contrast is few shades of gray, whereas low contrast is lots of shades of gray. There's very low difference between each step. Where here, this is high. So this is really steep steps, where this is low steps. Spatial resolution. So atomic details must be accurately recorded and with the greatest amount of sharpness. So spatial resolution refers to the smallest object that can be detected in a digital image. All radiographic image has some degree of unsharpness. There's no way around it. So, X-ray beams can be modified before and after it enters the patient. Beam alterations can improve the image quality and reduce dose. So, primary beam modifications, there's two types. There's filtration and collimation. So, we talk to you guys all the time about collimation. So, modification of the remnant radiation is a scatter control process. Scatter. So, interaction of X-rays with any matter produces scatter radiation. Scatter radiation provides little diagnostic information to an image. It detracts from the image quality with the creation of fog. Common methods to control scatter is grids. So we use grids and after it passes through the patient, so in the remnant beam, used to reduce the amount of scatter radiation reaching the image receptor. So it's after the patient but before the image receptor. Interception of part of the remnant radiation. It improves image quality. Grids absorb according to the grid ratio and the frequency. So you have to change your technique and when you're using a grid because it's going to absorb some of the density. So you usually have to compensate for that. So you have different types of grids, and there's focus grids, parallel grids, there's 5:1, 16:1, everything in between. All right, so half value layer is the amount of absorbing material that will reduce the intensity of the X-ray beam to half its original value, used as a way to express the X-ray beam quality. So absorbing material is usually aluminum and expressed in millimeters of aluminum equivalency. So just so you guys know what the half value layer is, I'm introducing it now. All right, so the radiographic image. So if we look at it, absorbed radiation creates increased brightness or white areas on the image. So you can see the spine here has increased absorption of the photon, so it's going to give you white on your image receptor. The transmitted radiation creates a decrease in brightness or black areas on the displayed image. So you can see the descending colon there. So we've got air, which is giving us black. So there's various shades of gray recorded on the image to make anatomical tissues visible. So we can see the psoas muscles, we can see the liver here, we've got the bone, so we can see the iliac crest, and you can just see all the different anatomical structures. So we need some absorption and transmission. We need a combination of both in order to see the anatomical tissues. All right, so the imaging chain. Primary radiation from the X-ray tube travels through matter and its energy is finally detected by the image receptor. So remnant radiation creates chemical changes within the receptors that are visible. It's called a latent image. So once the image receptor has an image on it, but we can't see it, it's called latent. So a latent image must be processed and converted to a visible image. So we have film screen, fluoroscopic imaging, digital or computerized imaging. So with film screen, X-rays create a permanent image on a piece of polyester. It consists of X-rays directed at a radiographic cassette, and within that cassette there's intensifying screens. So the intensifying screens convert the X-ray energy to light. And the light energy creates a change, a chemical change in the film. So the exposed X-ray film is chemically processed with a wet chemistry automatic processor. So processing converts the latent image to a manifested image. So the latent image is the image we can't see, and the manifested image is the image that we can see. So once it's processed. Radiography is analyzed for quality, or the radiograph is analyzed for quality and submitted to the radiologist for interpretation. And it is being replaced by CR and DR imaging, which is great. So film screen receptors. So radiographic film has been the primary recording media for decades. It uses special film that is sensitive to light energy from an intensifying screen. The light from the screen causes chemical changes, gives us a latent image. Film with the latent image is processed through various chemicals to yield the manifested image. Film is between two layers of intensifying screens. I think I showed this to you guys in class. With a light tight cassette. So light tight means no light goes inside the cassette. The cassette with film and screen is exposed to the remnant radiation. The film is removed from the cassette in the darkroom and placed in automatic processor. The processor gives us a manifested image and requires a lot of quality control to make sure everything's working properly. All right. Okay, so the reason why we use intensifying screens is it lowers the dose to the patient. All right. Limitations of film screen. It has a limited dynamic range, and we're going to talk about dynamic range in your 110 class, in your recording media class. The cost of film and the processing, there's silver within the film, and we have to reclaim all the silver. It gets very expensive. It has a long processing time. The processors are usually 90 seconds per film, and that's after you get in the darkroom. So there's no post-processing or adjustments of the film, and has limited contrast resolution, and it cannot be stored electronically, so you have huge film archives, so you have to go pull all the films. Okay, so image receptors. So image receptors detect the remnant radiation from the patient and convert it to a chemical or electronic changes that make up the latent image. There are 3 types. So we talked about the film screen already. Now we're going to go into the photostimulable phosphor system, which is what we call computed radiography. And then there's digital detector systems, and there's direct and indirect. So PSP, photostimulable phosphor, storage phosphor, so also known as CR. And CR is a storage phosphor technology. It uses a cassette with the imaging plate. The plate is reusable for thousands of exposures. Exposed imaging plate in a cassette is placed in the reader for electronic processing of the latent image to a manifested image displayed on a monitor. So it eliminates the need for X-ray film or a darkroom, and ultimately creates a digital image through computer software. And we're going to talk about that whole process. So exposure to the plate is stored in a barium fluorohalide crystals that create electron traps. It requires the optimal combination of mass, KVP, and SID for optimal image quality. So you have your incident photons, it goes to your cesium iodine scintillator, your light, FET or FTFT, and we're going to talk about this whole process. I just want to give you an idea what your computed radiography is and does, but we're going to go deep into this in your next class. So you have a CR reader. So the cassette is placed in a CR reader. Reader scans with the imaging plate with a laser energy and recovers the energy from the electron traps. So when you expose a CR plate, the electrons go up into a higher level state in these areas called traps. So the laser will release the energy of those electrons and drop them down to a lower energy state. When it does, it gives off an image. So the energy converts into a manifested image. So digital or cassetteless system. So there's 2 methods for image capture. There's indirect and direct. The image resolution is determined by the pixel size of each data element. So there's more than 1 million pixels per image. So images consist of pixel elements in a rectangular array. So both methods use a thin film transistor technology. So it's the TFT. And like I said, we're going to go deep into this in your next class, but you just have to have an idea what this stuff is. Okay, so exposure considerations with DR detectors. So several key factors must be considered when evaluating proper image receptor exposure. So you need to look at your exposure latitude, your exposure index, and your automatic scaling. So digital detectors possess greater exposure latitude than conventional film, so you guys are able to use a wide range of techniques and you guys can get away with it. When we had film, there was no getting away with it. DR systems can be operated at varying system sensitivities known as system speeds. So the faster the system, the reduction in quality. So the slower the system, the better the detail we're going to see. So here's your EI, so your exposure index. It's a numeric representation of the total X-ray exposure to the receptor. So it's not an indicator of the patient's absorbed dose. Values can vary among manufacturers. So you have all these different brands. So you have your S or EI or whatever. So there's different ones. So when we come see you, we're like, okay, what are you using? And we've been doing it so long, we can figure out if the image is exposed properly. So professional technologists will thoroughly understand the significance of the EI value and use it the way you're supposed to. So an exposure index number are adopted by the profession. A more reliable DI, so deviation index, will be used to measure the patient's exposure by the radiographer. So we can tell if you're overexposed or underexposed so that we can get great images and keep the dose down to the patients. So automatic rescaling. So the computer software optimizes image quality by varying the brightness and contrast of the image on the basis of the exposure to the receptor. So too little exposure results in noisy or grainy images. So we call that quantum noise. Too much exposure technique can reduce the image contrast because we have the gray fog on there from all of the scatter. So automatic rescaling is no excuse for exposure technique selection inaccuracies. So make sure that you're using the proper techniques. All right, image display parameters. So digitally created images are viewed on television monitors, computer monitors. So images can be adjusted in terms of brightness and contrast. So you have your window level, and your window level controls your image brightness, whereas your window width controls your contrast. So we can change the window level and the window width to make the image look pretty. All right, direct detector technology uses amorphous selenium as an active detector material, uses the TFT to capture the electrons from the X-ray interactions. The TFT collects and amplifies the electronic signal. The electronic signals are converted to computer data and are displayed as an image. Indirect uses a scintillator material bonded to amorphous silicon. Scintillator receives the X-ray energy and converts it to light. The light energy is captured by amorphous silicon and converted to electrons. Electrons are collected by the TFT and sent to the computer. So direct does not use the conversion of light. So as you can see here, it uses amorphous selenium and it goes directly to the computer for an image, where here it has a second step where it takes it and converts it to light. All right. So on digital radiography key features, no cassettes, yippee. Image displays in seconds, yep. Detectors can be direct or indirect, and both type use thin film and transistors. And like I said, we'll talk deeply about that. Indirect detectors use cesium iodine as a scintillator with amorphous silicon, and brightness of the image is not the same as radiographic density and not related to exposure. So geometric qualities. All right, here we go. So they contribute to the image quality by affecting image resolution, size, and shape. They're also known as recorded detail, sharpness of detail, and definition. So we call it different things. Complemented by visibility of detail, which is a photographic property. Okay, factors that affect our recording detail. Motion, number one. We want to get the motion out if we can. The object unsharpness, so the size and shape of the object. Focal spot size will affect our recorded detail. Our SID will affect our recording detail. Our OID, so object to image distance, will do it also. So we want to keep the OID as low as possible. Keep the part as close to the image receptor. The material unsharpness and distortion. So let's talk about these. Recorded detail and motion. So motion distortion is the most common cause of unsharpness. Caused by voluntary and involuntary motion of the patient. It can be controlled with short exposure time, patient immobilization, suspended respiration, and effective communication. Very important that you get the motion out. So object unsharpness, so loss of resolution caused by the inherent shape of the patient's anatomical structure relative to the divergent beam of the x-rays. So it's lessened by the optimal use of focal spot size, OID, and SID. So loss of resolution by dimensional shape of the actual target area on the anode surface. So we have, it's called penumbra, so changes in unsharpness as the focal spot size increases. So this is your penumbra here. So this middle area is umbra, and you have penumbra. So the larger the focal spot size, the larger the penumbra. So it's geometric unsharpness at the edges of your image. So focal spot size reduced by using the smallest dimensions possible based on X-ray tube manufacturer specification. So I know your textbook says to use a small focal spot size on a chest. Don't do that. It'll burn out the tube. It can't handle the heat load. So although we want better detail in the chest, we still go with a larger focal spot size. All right, source to image distance, SID, the distance between the X-ray tube and the image receptor. So you want to make sure that you have the furthest distance. It will give you a straighter beam going through the anatomical part. And here, the distance between the patient and the image receptor, so your OID, the further away the part is from the image receptor, you're going to have magnification. With magnification, you lose your detail. So we want to keep the OID as short as possible, SID as long as possible. Material unsharpness, so its loss in resolution is caused by the inherent characteristics of the image receptor material. So film screen unsharpness is a result of the size of the silver grains within the film emulsion and the size of the phosphors in the screens. Digital detector unsharpness is caused by the pixel element size of the detector technology. So distortion, any misrepresentation of the true size or shape of the patient's anatomy as demonstrated on the radiographic image. There are two types of distortion, there's size and shape. So distortion, so radiographic misrepresentation, either size or shape of the anatomical part. So size distortion or magnification is an increase in the object's size compared to its true or actual size. So SID and OID affect magnification. So you want to use the longest SID and the shortest OID. Shape distortion is a misrepresentation of the object's image shape, so elongation or foreshortening. So the central ray alignment of the X-ray tube part and image receptor affect distortion. So if we look here, we have motion unsharpness, so you can see that the patient's breathing, so that's not good. And then we look at our shape distortion. So A, this is normal. So this is foreshortened due to the misrepresentation of the part to the image receptor or the beam alignment. Where this is elongated, so this is same thing, so misrepresentation of the true size and shape. So size distortion is always slightly larger than the actual size. This is known as true size distortion. It is minimized by using longer SIDs and minimizing OID. Shape distortion, any representation of the true shape of the patient's anatomy, also called true distortion, controlled by alignment of the central ray, patient anatomy, and the IR. So you need to make sure that your central ray, your part position, and your IR, and your image receptor are all aligned properly. If not, you're going to have shape distortion. So it may be deliberate to deal with superimposition of structures. So sometimes we use that to see things a little bit better. So deliberate distortion, accomplished by angling or rotating the patient's relative to the central ray or the X-ray beam. And we do this, right? It helps to overcome superimposition of anatomical parts. That's why we do it. All right, so scatter, we're going to talk about this again. It's unwanted exposure to the image receptor resulting in fog as a result of Compton interactions. Provides no useful information. Scatter or fog decreases image contrast. Digital image receptors can detect lower levels of radiation intensity and therefore more sensitive to scatter. So this is what it looks like. So this should be real clear. We should be able to see the lungs really well. And you can see there's like a layer, like you fogged up a mirror in the bathroom when you take a really hot shower. And if you were to wipe away all the fog, you'd have a perfectly diagnostic image. So there's a layer right on top of it, just like a steamed up mirror. So if you wiped away all the steam, you'd see a perfect image. So is there a decrease in image quality on the actual image? No. Is it decreased due to scatter or fog? Yes. But this detail is still there. It's just covered up by the fog. All right, so quantum noise. It's visible as brightness or density fluctuations and is photon dependent. So quantum noise is too few X-ray photons results in increased quantum noise. So it has no useful information. You're missing information. So it's more visible on digital imaging. And you can see here, I can't see in here really well. So there's there's a miss in information. I can't tell if there's a hairline fracture in here or not. So the image is starved. Usually it's because the KVP is too high. So when you're phototiming, it shuts off too soon, and this is what we call quantum noise. Oh, artifacts. How many of you guys have done this? I know I've done it before. You need to make sure you clear our artifacts from your image because it will degrade your image quality. All right, fluoroscopy. We're just going to touch on it real quick. You're going to have a whole class on fluoro. So, use of x-rays to create real-time images of the patient's anatomy and function. So, x-ray exposures are much less than radiographic exposures. It requires a radiographic or fluoroscopic x-ray system with image intensifier. So, it's got a different image receptor. It's called the image intensifier. Physicians can observe the body's physiological actions. So image taken during fluoroscopy are digital images, so we can actually take still images during this time. Images can be played back for review and sent to an archival system for long-term storage. All right, so in conclusion, optimizing image quality is a delicate balance among various X-ray imaging parameters. So there's a lot of different ways we can control it. Digital detector technology is replacing film screen. Yep. Digital technology offers greater exposure latitude at lower doses. True. I don't know about lower doses. A lot of people do what's called dose creep. And so if you overexpose, you're fine. If you underexpose, you have to repeat. So what happens is they slowly keep increasing their doses to the patient. So keep an eye on your EI and make sure that you're not overexposing all your patients. The technologist is responsible for using the lowest exposure necessary to achieve optimal image quality. So, long lecture, tons of information. Really important that you are familiar with all of this. So this is your platform moving forward. So your physics class is going to be based off of this in the next 2 semesters. So important that you kind of get a grip on this and understand the basics. All right, watch this PowerPoint. Go through the PowerPoint, read the 2 chapters, and you'll do great.